Good afternoon, everyone. I'm delighted to welcome you to the 2023 Freedom of Expression Public Policy Symposium. We are delighted to have you here. My name is Allison B.A. I'm the Executive Director of the Goldfarb Center for Public Affairs here at Colby College. I am delighted to be hosting this event tonight, this afternoon, for the policy competition that has become an annual event. I would like to just acknowledge that this event is made possible because of the generous support of Bill Goldfarb, and that name might be familiar because, in fact, the Goldfarb Center is named after Bill and his incredible support of Colby and of his true dedication to making sure that there were plenty of opportunities on campus for students to really dig into thorny public policy and political issues from whatever persuasion. And so this event really only exists because of his support, and we're really excited to be able to do it again this year. Every year, the Goldfarb Student Advisory Board picks a theme, and this year the theme was healthcare, an issue that is an issue both here in this country and abroad. And so the competition this year, we asked students to compete to think about what is one of the most pressing issues related to access to healthcare and how might you solve it. And that's what we're going to hear from students about today. Before we get into the competition, I want to thank our faculty panel. We're really excited and appreciative that you're here and part of this. We have Professor Kessler from sociology. We have Professor, we worked on this before. Professor Jersey is how he allowed me to say it, but I'm going to, Professor Vercharak and Professor El-Sharari, who is our faculty director at the Goldfarb Center. We're very grateful for her leadership, so thank you, and thank you to you all. What we're going to do this afternoon is we're going to hear from our 7 teams who competed on this issue. They're going to come up, they're going to speak for about 6 minutes and give their presentation. They have submitted both a policy brief and then they also have a presentation to offer. And we will hear from each team, and at the end of that presentation, the judges will take a moment and go back and evaluate, and then we will have award first, second, and third prize. So that is how we will move on throughout the afternoon. I'm really glad to see a bunch of students here, and Professor Maisel, we're really happy to have you in the audience as well, as the first director of the Goldfarb Center who gave us all our start. Wouldn't be here without you, so thanks for coming today. So without any more discussion, I'm going to leave it up to you. The only thing I will say, as someone who has worked in public policy and law for the last 25 years, I was incredibly impressed with the work that you did, with the commitment you showed. Not only did you take very complicated issues in your written proposals, you also translated those into a really very powerful presentations, and I can tell you that there's many ways to win a policy debate, but it's not always through words on paper. And so I'm really excited to see the work that you did, continue to be incredibly impressed with Colby students, and excited to see what you can do with us this afternoon. So with that, I would like to welcome our first team up to the stage, Sonia Marnato and Cleona Kenny, who will talk about Chipping In with CHIP, Investing in Healthcare Accessibility for America's Children.
Hi, I'm Cleona Kenny.
And I'm Sonia Marnato.
Thank you so much to the Goldfarb Center for giving us the opportunity to speak about our policy today.
According to the U.S. Census, the rate of uninsured children fell by 5% in 2021. While this number may seem impressive, there was no reported change in coverage for children in families with incomes below or around the poverty line. In fact, 4.165 million children in the United States remain uninsured. Therefore, while it is tempting to believe otherwise, the U.S. is clearly failing to provide adequate coverage to some of the youngest and most vulnerable members of our communities, children in poverty. Our proposal aims to tackle this issue by increasing the affordability and accessibility of CHIP.
Created in 1997, CHIP enhanced Medicaid by providing coverage to children who had previously been ineligible. 26 years later, many families covered by CHIP are still experiencing the economic burden of cost sharing and the barrier of physically accessing healthcare at alarming rates. To tackle the economic burdens of CHIP, We propose a two-pronged solution. First, CHIP should implement income variability for copayments, premiums, and deductibles. Second, Congress should implement a block grant to CHIP programs for a firm fixed-price contract to increase physical healthcare accessibility via a mobile healthcare bus service.
Insurance companies typically charge two types of fees for healthcare access: premiums and copayments. A premium is the monthly payment you make to receive the coverage. Copayments are fees that you pay each time you go to the doctor's or order a prescription. According to the CHIP income guidelines chart shown above, CHIP adjusts the prices of monthly premiums based on the age of the qualifying child. Essentially, the younger the child is, the less the family has to pay each month. However, as you can see in the red circle on this chart, CHIP provides no income variability for premiums or copayments. This means that one family covered by CHIP could be expected to pay the same bills as another family making 4 times their income. These two families with drastically different incomes are paying the same copayment for doctor's visits, brand name prescriptions, generic prescriptions, specialty visits, and emergency visits. We believe this makes CHIP more expensive than it should be, creating large financial burdens for families who just want to keep their kids healthy.
In order to increase equity and accessibility under the existing CHIP programs, states will take these steps to determine the cost of deductibles and copayments for families covered by CHIP, with a view to expanding the programs for Medicaid in future years. First, states should identify the range of qualifying incomes for their CHIP program. Second, they should divide this range into 4 equal income brackets. Once they've identified their brackets, they can determine the cost of copayments and deductibles using this chart. As you can see, this chart uses federal qualifying limits for a family of 4 under CHIP and a $100 copayment as an example. Families in the highest income bracket will pay 75% of the original cost of any copayment or deductible. Families in the second highest bracket will pay 50% of the original cost. Families in the third highest bracket will pay 25% of the original cost, and families in the lowest income bracket will pay 0% of the original cost of any copayment and deductible.
CHIP's existing program also fails to provide support for families who face economic and physical barriers to healthcare. For example, a low-income family or a family living in rural communities may not have the time or the money to drive their children to appointments. It is necessary that CHIP works to overcome these barriers so that barriers to success for kids such as poor eyesight, dyslexia, or ADHD are caught early. The adoption of a free mobile health clinic service for newborns to children under the age of 18 who are uninsured or benefit from Medicaid or CHIP would significantly lessen barriers that children face throughout the country to access healthcare.
Therefore, we propose a firm fixed-price contract of $1 billion per year for 5 years to fund mobile healthcare units modeled after the buses operated by the Children's Health Fund. The Children's Health Fund, a 501c3 nonprofit, has successfully run mobile healthcare units throughout the country since 1987. Their buses provide subsidized services including vaccinations, physical examinations, dietary consultations, mental health services, social work, health education, and healthcare benefit consultations for children's families. The mobility of a bus accounts for barriers such as appointment availability, inaccessibility of specialty services, and transportation, ultimately making healthcare more accessible for working and busy families.
This proposal will require financial support from Congress. Currently, each healthcare visit provided by the Children's Health Fund costs roughly $31.25. Based on this price, by investing in a firm fixed price contract of $1 billion per year for 5 years, the mobile healthcare bus service would guarantee at least 32 million free healthcare visits for U.S. children. With this high FFP, we anticipate the interest and competition from for-profit organizations that would be willing to invest in the building and transporting of these healthcare buses. This immediate investment would help to jumpstart the program and provide appointments to uninsured children. We believe that the initial $5 billion investment for this policy would help remove the barriers that stand in the way between America's youngest generation and accessible healthcare.
Therefore, we encourage you to join us in chipping in with CHIP. We can make a measurable difference by choosing to invest in the health and well-being of America's youngest generation. Thank you for your time.
Thank you.
Thank you so much for getting us to a great start. Now we're going to hear from Ana do Rosario. The malady is in the monopoly.
Good evening, everyone. Today, in the 6 minutes allotted to me, I'm going to attempt to convince you that the real malady plaguing the United States right now is not diabetes or any other biological pathogen. The malady is the monopoly on healthcare. So to outline the magnitude of the problem, consider this. The United States spends 2 times as much on healthcare as the other 12 most industrialized nations. In fact, the United States spends more on healthcare alone than the country of France spends on everything. That includes chocolate, caviar, champagne, what have you. Despite the spending on healthcare, it doesn't justify the medical outcomes. The United States remains last in healthcare outcomes, last in life expectancies, and most deaths from avoidable medical problems among other industrialized nations. Now, this is not inherently problematic. However, we said that outcomes do not justify the spending. So what is the root cause of such high spending and no medical outcomes to show for it? As illustrious Princeton economist on healthcare stated, it's the prices, stupid. This is actually very iconic. If you do a Google search of this, there's nearly 10,000 hits citing this seminal work. And another notable expert in this field, Robert Pearl, elaborated on this further in what he calls a conglomerate. I'm just going to switch over. Conglomerate of monopolies, a three-headed hydra, if you will. It consists of hospitals and healthcare systems, doctors backed by private equity, and drug and device manufacturers. So for a quick refresher on monopolies, and if you're a Taylor Swift fan, you likely already know this, whenever there is market consolidation, the result is almost always limited competition, diminished choice, and higher prices without added value. This three-headed hydra kills innovation, and it's bringing down affordable healthcare with it. Now, if we think of the task at hand as waging a war on this three-headed hydra, these are 3 different theaters, and the following policy proposal will tackle the front of hospitals and healthcare systems, specifically mergers and acquisitions. Now, to provide some specific context for hospital mergers, about 1/3 of all emergency and acute care facilities are owned by only 40 of the largest health systems. 1/6 of all hospitals are owned by the top 10 health systems and combine for over $300 billion in revenue. Now, however, there are actionable ways in which we can work within the merger and acquisition system and the existing ecosystem. First, by leveraging existing economies of scale for good. Right now, hospitals use consolidation and mergers to raise prices and exercise monopolistic control over certain areas. They continue to schedule ortho procedures, neuro procedures, and cardio procedures across all low-volume locations, which does not eliminate inefficiencies. Instead, they can combine cases in each specialty into centers of excellence, focusing on each of the specialties. This would increase case volumes for operative teams, and this would allow them to augment their experience and expertise, thereby returning the innovation that was previously stifled by monopolistic control. This allows them to provide care at a fraction of the cost rather than offering duplicative services. In fact, the consumer does indeed benefit when we apply this economic theory to reality. In this specific case study that I want to highlight, Allentown Hospital in Lehigh Valley in Pennsylvania merged. While Allentown specialized in OBGYN, pediatrics, and other services, Lehigh specialized in the secondary and tertiary care. Now, given the merger, Lehigh also had the capital and infrastructure to operate state-of-the-art equipment, techniques, and they ultimately developed a market for a very specific specialty such as open heart surgery. Next, it's time to bring back the hospital-at-home model. 1 in 4 patients will experience a medical error during a hospital admission. Avoiding risks of being an inpatient can be equally as life-saving as highly attentive care. During the pandemic, non-emergent inpatients were sent home due to a lack of beds. This resulted in lower costs for patients who were sent home and faster recoveries. We need to build on this progress and not regress. Using readily available assistive AI technologies, we can automate more bureaucratic and administrative tasks, and this will allow caregivers to operate from a centralized location and provide asynchronous and remote care to hundreds of patients in their homes around the clock. And please don't just take my word for it. In a study of this Johns Hopkins hospital at home model, they found that the mean length of stay decreased and the incidence of delirium was also lower. In another study using quasi-experiments, in 2 out of 3 site studies, they found that about 70% of patients preferred hospital at home care over more traditional care. The total cost of at-home care was about 30% less than traditional brick-and-mortar care. And this is significant, both statistically, if you look at the data, which is in the appendix, if you look at the data, and figuratively, if you think of the exorbitant prices that currently exist. So, some key takeaways as you're leaving. The monopoly problem is multifaceted. We looked at this before. It's like a 3-headed hydra. We're not going to solve this in a week, a day, a month, or even a decade. However, if we tackle the specific facet that I previously mentioned, it is a significant step towards progress and a significant step towards a solution, especially given that other solutions through PATS in Congress and the Senate are not feasible given the very slim margins that currently exist. There already exist proven benefits in the hospital merger ecosystem, and proven benefits and tangible solutions to addressing this facet of the 3-headed hydra by leveraging the economies of scale and adopting new innovative models such as hospital at home and assistive AI technology. That is how we will be one step closer towards curing the malady of monopoly. Thank you.
Thank you. Next, we have remind me again. Saya. We did it well earlier, and then Saya Patel, Doctoring in a Drought, How the Shortage of U.S. Healthcare Professionals is Leaving Patients Thirsty for Care.
Hi, good afternoon, everyone. My name is Sai Patel, and I'm a first year at Colby. I'm here to speak to you about an issue that is important to me, healthcare, and why we can't access it right now. So I'm going to start this presentation with my definition of access to healthcare, which is the ability to obtain affordable, effective, and timely healthcare services and attain the highest level of health outcomes, regardless of geographic location. As a frequently sick college student, which I'm sure my professors can attest to, I've had more than a few visits to the campus health center and Maine General this semester. Waiting to be seen by literally anyone got me thinking about why there seems to be a consistent theme of healthcare worker shortages in rural New England. Primary care providers, or PCPs, and patients are being failed by the current inaccessibility to adequate forms of healthcare. Due to the lack of PCPs in rural areas, costs of healthcare are rising. There are poorer overall health outcomes, and patients have to travel further for delayed, inadequate care. Access to healthcare is no longer affordable, effective, or timely. As the most rural state, Maine has the highest percentage of people needing the most health care, but the lowest percentage making up the vast majority of the workforce. Maine already has a PCP shortage and ranks last for patient satisfaction of physicians, with a large nursing shortage in long-term care facilities. More PCPs have experienced burnout, have less job satisfaction, resources, funding, and time to devote to training new PCPs. So the goal is apparent. We must increase access to the number of PCPs, especially in rural regions. Executing a policy intervention to address the shortage requires a multifaceted approach involving collaboration among federal, state, and local governments. This can be accomplished by increasing financial incentives for PCPs to work in rural areas, including loan forgiveness programs and tax incentives. Rural healthcare facilities require additional funding to attract and retain PCPs, upgrade facilities, and invest in new technology. Increasing investment can help address this shortage in the long term. Expanding telemedicine services, allowing patients to receive remote consultations, alleviating the PCP shortage, and supporting partnerships between PCPs and local organizations, bringing together expertise, funding, resources, and technology to address the needs of rural communities. But for there even to be telemedicine innovation or enough PCP organization collaboration, funding is required. So the largest impediment is the unavailability of healthcare education institutions and training programs. Therefore, this aim would provide funding to create more accessibility. So these are a few state and federal programs offering financial incentives. The Maine Health Access Foundation is Maine's largest nonprofit healthcare foundation dedicated to promoting access to quality healthcare by providing grants to support the development and expansion of local healthcare education programs. Kansas offers tax incentives to healthcare institutions that establish new programs in rural areas. Federally, the Department of Health and Human Services offers grants to mitigate the nurse shortage, while the Rural Healthcare Services Outreach Program, or HRSA, provides funding to create and develop healthcare education programs. However, no federal initiative currently exists that offers tax incentives to increase the number of healthcare institutions. Among these examples, the HRSA is the only federal approach involved in addressing this issue. It's the agency responsible for improving the health of the nation's vulnerable populations, including those in rural regions. I wanted to use a pre-existing program to tackle this issue. Although grants can be a more predictable funding sources, I believe that offering tax incentives would increase the efficacy of this program. Tax incentives reduce the financial burden on healthcare institutions that invest in recruiting and retaining PCPs, making it easier to offer competitive benefits and salaries, which makes the field more attractive to enter. Additionally, states would not have to rely on grants as one-time funding sources. Tax incentives provide a compelling financial incentive for states to invest in healthcare institutions, creating an impetus for private sector investors to support healthcare institutions and infrastructure. This leads to more sustainable development through the creation of long-term jobs and economic growth. They also offer more flexibility, as states can choose the healthcare institutions that they want to support and how they support them, which is helpful in rural regions where healthcare needs vary widely. Therefore, the outreach program should be expanded and receive a significant increase in funding. Increasing funding for a federal agency can be done through the appropriations process by working with lawmakers and advocacy groups to make a case for additional funding, applying for specific rural region grant programs offered by other federal agencies and other private organizations, forming partnerships with private sector companies and foundations to secure additional funding, and reallocating the existing budget to prioritize this program. By increasing funding for the expanded program, more rural communities would benefit from its services, and patients would have increased access to care. Sustainably investing in training programs ensures that there are enough PCPs to replace retiring providers and meet the growing demand for healthcare services in the future. And expanding the number and range of health education programs would diversify the emerging and existing healthcare workforce, which is essential for critically addressing healthcare disparities. Therefore, this federal initiative offering tax incentives and grants to healthcare institutions to address the PCP shortage is a promising step towards improving access to primary care and addressing the healthcare needs of rural communities, ensuring that all Americans have access to the high-quality healthcare that they both deserve and need. Thank you.
So next up, we have Susie Swan, Addressing Disparities in Harm Reduction Access, Syringe Services and the Protected Expansion of Operations in Marginalized Communities.
Good evening. My name is Susie Swan, and tonight I will be presenting on the disparities in harm reduction access as they pertain to people who inject drugs. Through the context of local community interventions, my policy brief will expand on how different environmental barriers and social determinants contribute to inequities in access through the lens of 3 critical populations and the overall opioid public health crisis. With 2.1 million Americans impacted by an opioid use disorder and an overdose death rate of 28 per 100,000 people in 2022, the United States continues to endure multi-system shortfalls in addiction medicine treatment. The politics of harm reduction and the stigma of addiction continue to halt the incorporation of evidence-based practices and in turn result in inequities where certain populations are burdened with limited support to navigate their recovery. For example, individuals with opioid use disorders who live in rural communities are disproportionately impacted by inadequate access due to various environmental barriers. Past research indicates a rise in unsafe injection practices among individuals who live 10 or more miles away from a syringe service program. Likewise, homelessness serves as an additional social determinant where unstably housed people who inject drugs face a 64 times greater risk of hepatitis C infection in comparison to stably housed people who inject drugs. Finally, many incarcerated populations across the U.S. face a disproportionate burden of lack of addiction medicine treatment, including access to medications like Suboxone and Methadone. My policy brief centers on these 3 populations with the federally protected expansion of harm reduction programs. First, I propose the expansion of current syringe distribution policies where improved access to sterile syringes may combat a rise in hepatitis C and HIV infections. Next, through the implementation of a mobile syringe clinic and syringe and testing clinic, my proposal combats the different environmental barriers that impact rural and unstably housed populations. Finally, I propose improved medications access and long-term rehabilitation services that will more holistically treat incarcerated individuals and support their eventual reentry into society in an empowered manner. First, the proposed needs-based syringe distribution policy ensures that people who inject drugs have access to sterile syringes with the quantity of syringes provided at clinics dependent on their reported injection habits. With increased syringe coverage and consequential reduction in syringe reuse and share, as well as other high-risk injection behaviors, this new policy will lower HIV and hepatitis C risk. For example, with 72% of current hepatitis C cases attributed to intravenous drug use, policies that ensure access to sterile syringes are critical if we wish to adopt or address, rather, the numerous public health burdens associated with the opioid crisis. Next, I propose the widespread implementation of mobile syringe clinics with opportunities to address current inequities in access present in rural and unstably housed populations. As often burdened by long travel times or limited by transportation, these communities may benefit from a mobile syringe clinic with increased ease of accessibility to sterile syringes and HIV and hepatitis C diagnostic testing. Likewise, these mobile syringe clinics may expand operations to include treatment referrals, as well as offer additional opportunities for communities to learn about community resources, trainings on resilience, and local support groups. Finally, I propose the federally mandated access to substance use disorder treatment in correctional facilities. With only 14% of prisons offering Suboxone or Methadone medication access, there is a critical need for enforced regulations that allow for continuity of substance use treatment pre- and post-incarceration. For example, past research has identified forced withdrawal of either methadone or Suboxone due to imprisonment result in a reduced likelihood of individuals continuing their treatment post-release, and thus lead to an increased risk and death from either overdose or high-risk drug use behaviors. Further, I propose that legislative efforts expand beyond addiction medicine access to also include the protected expansion of community-based rehabilitation services in prison facilities and prison reentry programs. This incorporation shall focus on a less punitive approach that emphasizes relationship building and community involvement, with previous research indicating individuals to be 47% more likely to continue their addiction medicine treatment when co-involved in a community support group. In conclusion, this 3-pronged approach expands beyond current harm reduction policies to address inequities in access as enforced by the stigma of drug use, environmental barriers, and social determinants of health. This culmination of improved access aligns with overall public health goals of tackling the opioid epidemic in the United States and further offers potential solutions of holistic treatment with tremendous opportunity to improve long-term health outcomes in a humanistic and equitable manner. Thank you very much for your time.
Next, we're going to hear from Safika Davidi, Access to Healthcare, Breaking the Cycle of Emergency Department Use.
Awesome. Good afternoon, everyone. I'm Sathvika, a sophomore here at the college, and today I'm here to talk to you about access to healthcare. But what exactly does that mean? So it's often thought of, implicitly thought of as this one-time event. So there's many programs like mobile healthcare clinics, for example, that offer resources for underprivileged, for the underprivileged, but they end up falling short in delivering consistent care. So they act as this Band-Aid for long-term health issues. While these initiatives are definitely a step forward, better health can only be expected when access to healthcare becomes this ongoing process of stable sources of medical resources. Without consistent care, what's happening right now is that patients don't have guidance about addressing their medical needs or even navigating the healthcare system. So oftentimes, their go-to source of care becomes the emergency department, even for non-urgent issues. In fact, recent studies have found that about 67% of hospital emergency department visits are avoidable. So this practice leads to inconsistent care and a strain on current emergency department resources. And the biggest contributing factor to this phenomena is the lack of primary care services, especially for low-income patients. Policies like the Affordable Care Act and the expansion of Medicaid aim to address this issue directly. And they've been successful to a degree, but the biggest gap that remains is this lack of sufficient primary care providers. And the main reason for that is the educational debt that healthcare professionals face. This often deters them from taking on positions that don't pay as much as positions in more affluent regions or specialties. So to tackle the larger issue of emergency department overuse, the best solution is to address the root cause by implementing a loan forgiveness program for healthcare professionals to work in regions where access to primary care is limited. Now, this is not a new concept, but one that needs a more effective implementation. In this proposal, I aim to enhance 3 key areas of focus: the eligibility criteria, the application process, and funding. So first, refining the eligibility criteria. Currently, one of the shortcomings of many loan forgiveness programs out there is that they only target physicians. But as we know, healthcare teams are most effective when they're interdisciplinary. So the first plan of action is to expand the criteria to include other critical professionals such as nurses, nurse practitioners, physician's assistants, etc. This would help address the workforce shortages more effectively and ensure a better team for higher quality care. But the complexity of the current application process makes it challenging to broaden current eligibility criteria. And it also makes it difficult for healthcare professionals to find programs that match their needs. And that frustration leads them to opt out of the program completely. So here, implementing a centralized application system that's similar to the residency match system, if you know how that works, would be increasingly beneficial. It'd be managed by one governing body, such as HRSA, and it would employ a matching algorithm to connect healthcare professionals of different specialties and different experience levels to their most suitable loan forgiveness program. In this way, we could also ensure the equitable distribution of healthcare professionals across different regions of need. And by incorporating experience levels, we can push this program onto both established providers and early career providers. So established providers would be matched with programs that offer greater levels of loan forgiveness, and the early career ones would be matched with programs that offer training opportunities in addition to loan forgiveness. Studies have shown that just participating in loan forgiveness programs increases the likelihood of choosing primary care as your permanent career path. So by streamlining the application process, we can increase participation in the programs and effectively manage the shortage of primary care providers in a long-term solution. But implementing this new system requires a different funding model than the current one, which relies heavily on federal and state funding. This sole dependence on the government creates uncertainty and the potential for shortages and cancellations due to lack of funding. To minimize this risk and ensure sustainability, the financial burden should be dispersed across various collaborative sources. So in essence, partnering with private organizations, in addition to healthcare systems and the existing government support, would ensure a more sustainable funding model. For instance, a relationship with a hospital may result in funding for the program in exchange for those professionals working for that organization later on. This would not only further the program, but also offer the participating professionals with the resources and support they need to provide high-quality care. In conclusion, while there are many potential solutions to address the problem of emergency department overuse and accordingly the limited access to primary care services, a loan forgiveness incentive program is among the most effective. By upgrading this policy in the three detailed areas, we'd not only diminish the bigger problem at hand, but we'd also benefit patients and the healthcare system overall. Patients will have increased access to affordable and continuous care in a primary care setting. That way they can establish relationships with their doctors and reduce out-of-pocket costs. At the same time, the healthcare system can operate more efficiently to reduce healthcare costs and ultimately provide better patient care. Thank you so much for your time.
So we have two more. We have now Sophie Peterson, who is going to be talking about community health workers bridging the divide between patients and providers by eliminating medical mistrust. I'm just realizing that the teleprompter was right there for me instead of looking down. So Sophie, please come up.
Hi, I'm Sophie Peterson, and I'm really excited to be here today. I'm a sophomore majoring in biology and Spanish, and I'm proposing a policy about the value of community healthcare workers in decreasing medical mistrust and increasing access to healthcare. The reality is that healthcare inequity has been around in this nation as long as discrimination itself. That's because discrimination in fields entirely unrelated to medicine, such as housing, employment, and education, have created a divide in access via financial, social, and geographical barriers. This divide also allows the people in power, like those that run the healthcare system, to take advantage of people with less power, like those of marginalized backgrounds. And the reality is that a lot of the most celebrated moments in medical history are just that. I'm thinking of the story of Henrietta Lacks, a Black woman whose cells were taken for culture and discovered to be immortal. They were used to decades to further medical research without her consent or compensation. And this history of substandard care for marginalized patients is still very much alive today. As recently as 2015, over half of medical students believe falsities about inherent biological differences between Black and white patients. This misinformation combines with stereotypes and biases to create substandard care. Patients of marginalized gender, race, and socioeconomic status are all more likely to report discrimination in healthcare than their more privileged counterparts. In a world where medical education is finally starting to realize the harm of this discrimination, there is hope for change. The first step in that change will be for the healthcare system to rebuild the trust with marginalized groups that it's lost over centuries of failure. This current lack of trust is called medical mistrust, and it has real, concrete consequences. Patients with less trust in the healthcare system are less likely to attend wellness visits and more likely to have poor health outcomes overall. Medical mistrust is a completely reasonable response to the failure of the healthcare system, and it's the responsibility of providers to rebuild the trust that's been lost. Studies have shown that patients with improving relationships with their providers are also more likely to have improving health outcomes, and patients can trust their providers even when they don't trust the system at large. In my opinion, one policy can't possibly fix the fact that the entire healthcare system has been built on other systems of oppression, but it can begin to rebuild individual patient-provider relationships and give patients the benefit that come with those strong relationships. The policy that I propose is the implementation of community healthcare workers in every hospital across the country. What are community healthcare workers? They're members of the patient care team that come from the community being served. This makes them uniquely situated to understand the needs of individual patients, and that's exactly what their job is. Community healthcare workers might conduct home visits to make sure that treatment plans can be followed. They might follow up with patients who've had visits to make sure that they felt like their needs were met. And they might set patient-provider relationships up for success by acting as an interpreter of sorts. These community healthcare workers would be proportional in quantity to the size of the community being served, and initial funding for the program would be provided by the federal government with the hope that it could eventually be repaid. Is there evidence that community healthcare workers can reduce health inequity? Yes. Several programs around the nation have already shown just that. One hospital in the Bronx that added community healthcare workers to their patient care team saw a 5% reduction in emergency room admissions and a 13% reduction in rehospitalizations of patients with chronic illnesses. This program and a similar one at the University of Pennsylvania found that for every $1 they spent on community healthcare workers, they saved $2 in continued care. This is a great example of how these programs can begin to pay for themselves if they just have the funding to get started. The Bronx program detailed how they added community healthcare workers to their healthcare system, and this could be used as a protocol by other hospitals in the nation. Multiple studies have also reflected the success of community healthcare workers in increasing health-promoting behaviors in their communities, such as practicing healthy lifestyle choices and following treatment plans. Patients who received care from community healthcare workers described an increased sense of self-worth, support, and trust that the program was there to support them. In conclusion, programs around the country have already shown that community healthcare workers are effective in increasing patient-provider relationships and giving patients the benefit that come with those strong relationships. In my opinion, community healthcare workers are essential in providing quality, equitable care to the patients in our country who've been denied it for far too long. Thank you.
And we'll hear from our last team. We have Michelle Bechtel, Justin Kim, Helen Wang, and they are commenting on remove the cap, expand the map, increasing residency positions and rural healthcare coverage.
This past January, I had the incredible opportunity of working at the Center for Cancer Care in Augusta. And one day, I met a patient and his entire family who lived over an hour away in a trailer. Every single day, this family would drive an hour to Augusta and back so that he could receive his treatment. They did this every single day. This map represents the areas in Maine that are roughly an hour away from that cancer center. But what about the people who live further? How would they have consistent access to treatment? Well, the answer is they wouldn't. Good evening. My name is Michelle, and along with my co-policymakers, Justin and Helen, we have a solution to this problem. You see, there are many problems with accessing healthcare, but one of the most prominent issues is the increasing physician shortage. Despite more medical students now more than ever attending medical school, the number of residency positions is capped at a distinct level. And this cap is determined not by the number of available residents, but by the amount of funding that the hospitals receive. This issue is exacerbated in rural areas because with a lack of physicians comes longer wait times to schedule appointments, farther drives to receive care, and less personalized care from doctors who have to see dozens of patients every single day. And with this decrease in overall quality of care, patients become discouraged from seeking treatment in the first place. Our policy is a solution that includes two prongs: remove the cap and expand the map. First, federal funds must be allocated to the Centers for Medicare and Medicaid Services. This is the institution in charge of determining the number of annual residency positions, meaning if they had more funding, this cap would not exist, which would increase the amount of annual residents and therefore doctors in the future, effectively eliminating the physician shortage. Second, specialized programs must be funded and provided for medical students to be committed to study rural areas, must be created and funded to commit medical students to studying in rural areas. These programs would be fully funded and cover the cost of medical school tuition, which would incentivize students to not only study in these rural areas, but to continue practicing in them after graduation.
Our policy aims to improve and expand on existing standards that are trending in the right direction but are lacking in scale and ultimately impact. Most recently, on December 21st of 2020, Congress passed a historic increase to the Medicare Graduate Medical Education Program, also known as GME, in almost 25 years. This expansion includes 1,000 new residency positions with priority in rural areas. While this is a step in the right direction, an increase on this scale cannot fully support the growing medical school enrollment numbers and the demand for physicians. However, the passing of this much-needed bill shows that Congress has recognized its necessity, which will likely expedite the process of allocating future federal funding to similar programs. Establishing rural medicine-focused programs also has strong precedents. For example, the Tufts Maine Medical Track is a program for students that are committed to pursuing a career in rural medicine, as you might be familiar with. This program has contributed to bringing more physicians to rural Maine. This policy seeks to expand on the success by implementing these programs across all rural areas in the United States. Our proposal has strong backing from existing policies and seeks to comprehensively expand the success of these policies in providing greater access to healthcare. As mentioned earlier, Congress has already passed legislation to increase the GME program, and therefore it is highly likely for this policy to be supported by Congress. In addition, federally funded programs that financially support students pursuing medical school are already well established. For example, the U.S. Army Health Profession Scholarship Program, or HPSP, fully covers the cost of medical school and even offers a monthly stipend to medical school students in exchange for mandatory service in the U.S. Army Reserve. Therefore, proposing a similar federally funded program has strong structural guidance, as it can be modeled after successful programs such as HPSP, and will ultimately commit more students to practice medicine in areas with limited physicians.
As we've mentioned, the physician shortage is vast and continues to grow. There are already so many requirements that medical students must complete on their road to residency. Those who are able to complete them are extremely capable and qualified doctors. So why are we making residency so selective? By allocating funds to secure a residency position for every graduating medical student, we can ensure that there will be more physicians overall. Secondly, by creating a specialized program that incentivizes students to complete their studies and residencies in rural areas, we can increase interest and enrollment, and as a result, bring more physicians to rural areas. We speak to you today to present a policy that removes the cap and expands the map, connecting more doctors with more patients overall, and especially focusing on rural areas. Ultimately, our goal is to make healthcare not only accessible, but guaranteed. Thank you.
I want to thank you all. I want to say I am so sorry. I am so sorry you have to judge this. This was exceptional. I have spent a lot of time in the state legislature listening to policy experts testify, and I would put you up against anyone, all of you. You did an exceptional job. You were concise. Your presentation skills are superb. And I'm so excited to hear students come up who may not have been in government or econ, and we've got students from all kinds of backgrounds really talking about the importance of policy in all of the disciplines here on the campus. So again, exceptional job. Apologies. And what we're going to do now is we're going to take a little break. The judges are going to go and deliberate about these spectacular presentations. We'll have some food, and then we'll come back in about 20 minutes to 25 minutes, and we'll hear from the judges, and we'll go from there. Thank you all very much.
Scott's Turf Builder Triple Action kills weeds, prevents crabgrass, and
Why are you looking through the couch?
I heard you could add 5 boneless wings to a burger for just $1 at Applebee's, and I swear I dropped a quarter in here.
You can get 5 boneless wings for only $1 at Applebee's? I'll be right back.
Limited time. Price and participation may vary. Limit 1 per order. Restrictions apply.
Thank you all. We are back. I hope you had a chance to visit with each other. I'd like to welcome our faculty back to the stage to give some comments and to announce our winners.
All right, sorry to keep you waiting. I've got to say this was impossible. We could have kept you waiting a lot longer. Just want to commend all of you on your exceptional work. I mean, really, these were spectacular. I know Allison already said this, but you just did tremendous work. You made our job extremely hard. We wish we could have given you all prizes because honestly, you all deserve them. It was really, really spectacular work. Really inspirational and beautiful. You know, we read your policy briefs really closely, and then we were just blown away by your presentations as well, and just the way that the work was exceptional across all of those formats was just really wonderful to see. So with no further ado, we'll start telling you who we eventually, it was very, very challenging, but we eventually awarded prizes, but just wanted to tell you all that it was excruciating and you did tremendous, tremendous work. All right, I'll turn over to...
So in the, starting with the third place prize, we would like to award that to Susie Swan for her proposal on addressing inequities and harm reduction.
Thank you so much. Sorry, I'm shaking it. Thank you.
Congratulations, Susie.
Thank you so much. Yeah,
we're so impressed with the amount of detail you put into your brief and your presentation, and the way it was so well tailored to a very specific problem and a very concrete set of populations and well thought out solutions. So well done, Susie.
And our second prize is going to go to Sophie Peterson for her proposal about community health workers. Congratulations. We were very impressed by kind of the depth of background that Sophie gave us about, thinking about the topic and thinking about kind of the history of the topic, as well as the policy solution. We were very impressed with the whole thing. Thank you.
All right, and our first prize goes to Michelle Bechtel, Justin Kim, and Helen Wang for Remove the Cap, Expand the Map. Congratulations. So we were really impressed with the way that you defined the problem and how well your proposed solutions matched with the problem, how you had thought about all these details, and also just the incredibly effective way that you presented the material both in the brief and in your presentation to us today. So thank you so much, and thank you to everyone for participating in this incredible and really inspiring set of policy proposals.
I would love to, again, thank you all for your incredible hard work. I hope you will continue to engage on this issue. I want to say, actually, the Deputy Commissioner of Health and Human Services is going to be on campus on Thursday. I'm meeting with her, and any one of your briefs could be something that we could give to her to think about for the state of Maine. So I hope you'll continue to stay involved. I would love to get a photo of everyone on stage before we actually leave today. I'll try to figure out my phone to do that. And again, thank you so much, and I hope you'll continue to, those of you who are graduating, congratulations. I hope you stay involved in policy work, and those of you who are still here for a couple years, I hope you will come get to know us at Goldfarb and continue to do the great policy work. So thank you again, and hopefully you can join me on stage for a picture.